perspective which are common, and this is where, is very important point for leader to understand that how he establishes the team. Okay, so this is about, okay, it's not moving. Can you move the slide? I don't know, because I went back. Sanjay, this.
Sir, you just need to press your down or up arrow. Or probably you stop the sharing and.
Okay, stop sharing. Okay. Because I have now 5 minutes left, so I want to quickly finish. Or should I again share?
Yes, sir. Reshare your screen. Yeah, it has come up.
Okay, now it is coming up, right? Okay. Now, so let me just show it to you, which are the, I consider, which are the, most common, challenges, in our industry today, because if you are a leader, you must know, oh, okay, now it is okay. Yeah, these are the key challenges which our industry is facing. I think most important challenge, I think Marathi will agree with me, is that the society today has got the negative perception about the private healthcare sector. We may not be considering this as a major challenge, but to me, this is a major challenge, because this disconnects the society from us, community from us. So when they are visiting us, they come with that negative perception, which is not good for us. So we have to see how do we overcome this negative perception. We know the reasons, because there are certain irrational regulation, there is a cost factor, and people really do not know what is the cost of delivery of healthcare procedure. And that's why this negative perception is being built up, and people are also, supporting at various factors. I'm talking. So this is the one. NCD disease burden, of course, it definitely is a greater burden. Shortage of healthcare workforce is a major challenge. Actually, this was a policy issue right from beginning, that we did not bother to make sure that we have adequate number of specialists. We focused on MBBS, and then realized that no, with MBBS alone, we will not be able to drive the modern healthcare delivery. So that is the shortage of the healthcare doctors, nurses, and of course, paramedics. I am very sorry to say, but there is no even council functioning even today. So the paramedics which we take are many times absolutely illiterate, sometimes untrained, unqualified, and we put them, and that also can jeopardize the patient safety. So on one hand, we bother so much about doctor's qualification, nurse qualification, but there is hardly any botheration about the paramedics. So there, I think this is one of the challenge if you want to worry about the patient safety. Financial sustainability is linked with the patient safety. The way government is bringing new schemes, trying to bring additional population within the scope of the scheme. Somebody is saying in the government that we will bring 70% population within the free healthcare delivery. Now, when they say free healthcare delivery, 70%, and they come to hospital with those illogical rates, the hospital will not be able to cross-subsidize with the merely 30 or 20% patient who are paying the full rate cash. And that is going to be the challenge, because once this financial sustainability is disturbed, I can tell you, without people talking in open, that patient safety will take the back seat. That is the most dangerous thing which government, regulator, all of us have to understand. Use of technology also, I mentioned other day that our life expectancy has gone up from 55 years at the time of independence to 70 years today. How it has happened? It is no magic. Obviously, it has happened because healthcare delivery has improved, technology has come in, And obviously, that is going to cost. So my slogan is quality healthcare or patient safety is going to cost. But absence of quality and patient safety may cost you the life. You must remember this point. So I think in a hospital, so I think once I have covered this point, the challenge for the leader in the hospital is to maintain that how hospital staff or structure is centered over the patient. That is what called patient centricity, seamless and holistic care rather than jig-jog. Whether patient is being made to run from third floor to ground floor, again to seventh floor. So that seamless and holistic care, that we are treating the human, not particular disease. That is the very new challenge. Application of technology, which is all the time evolving and cost associated, and empowerment for the department, review about the clinical and managerial KPIs. This again is the important point. That you have the CEO must keep eye on the KPIs which are managerial as well as clinical. And clinical KPIs, he has to do it through the HODs. So that means first HOD must monitor the KPIs, and then it should be done at the level of, I think that is, so these are the last slide tips for the leadership. Empowerment is the key, and most to the frontline staff. Retrain the staff on soft skills. Establish units of profit centers. I think this most of hospitals are doing it. Progressively adopt the bundle payment. That is the future of the healthcare. We will not be able to do without that. Open and blame-free environment. This is again very important for the sake of patient safety. Midterm review, which I mentioned with the HODs and down the line to share the KPIs. This is a very important line here. Follow people first to engage with the patient. So when I'm saying patient-centric, you should not forget of your own people. When you take care of your people, they will take care of the patient. And whenever you want to bring any change, don't do it with the help of 3-4 HODs. No, please try to get the message from down the line across through shared vision or shared decision, and then bring the change. And that is the way you will be having the people. So this is, I think, in short, 20 minutes, Sanjay, you gave me. I have covered this leadership. The rest, of course, our friend Santosh will cover. Thank you very much.
Thank you so much, Gyani sir. It was really wonderful. It's been a very long time since I have heard you, but not in person, but through webinar. I think my wish is fulfilled. So I think a very important session and a lot of takeaways from what Dr. Gyani just said. So quality is all about the culture, right? It's not only one person. And quality is not just the accreditation, but much more beyond what we do as NMBH, JCI, NMBL, etc. Collective responsibility and empowerment of the people is the key for achieving patient safety and quality in our hospitals. I think nobody would have seen that inverted pyramid that you had just shown us, sir. And I think it has really, triggered a lot of thinking in the audience that they have just seen. And also the anecdote of football that you just gave, that was really helpful. So boss is not the CEO. CEO is not the boss, but patients are boss. So I think that is something that we have, heard from you. And blame-free environment and culture. I think these are very important takeaways and in the messages that you have given to us, sir. So thank you very much. This was really wonderful session. So now we have another speaker with us who is also a very big name in healthcare industry, Mr. Santosh Marathe. He has, more than 27 years of work experience and mostly in healthcare. His career has transcended from manufacturing, consumer goods, and lately to healthcare as well. I have had, fortune to work with Mr. Marathe for so many years now in Apollo Hospitals, Navi Mumbai, and in Western region, where he currently occupies the role of regional CEO of Western region of Apollo Group. And under his regional role, he's also responsible for hospitals based out in Navi Mumbai, Ahmedabad, as well as Nashik. He also manages Apollo managed hospitals in Navsari in Gujarat and also Lagos in Nigeria. His earlier stint was with American Hospital Dubai as a CFO. He has been instrumental in multiple strategic advisory roles for building business alliances, project planning, service excellence initiatives, costing and pricing strategies, physician compensation strategies, revenue management and IT implementations, etc. He also played a lead role in implementing ICD-10 as well as CPT migration strategy in his earlier role at American Hospital in Dubai. He has been recognized and awarded in top 100 healthcare leaders by IFAH Dubai. He has been a regular speaker in multiple national and international forums in many countries on various topics like big data, supply chain management, patient-centric care initiatives, patient experiences, finance and costing, IT systems, digital healthcare roadmaps, revenue management, so on and so forth. He will speak about strengthening leadership as a catalyst for enhanced patient safety culture. Mr. Marathe, please.
Thank you, Sanjay, and thank you for the wonderful presentation, Gyaniji. I think the football analogy was something which was quite interesting. Yeah, so while we speak about patient safety culture, I think as long as the time that medicine has been in practice, I think unnecessary and unintended harm has been a part of reality for most of the healthcare provider. And as we always keep on saying, nobody comes to work to make mistakes. I think mistakes do happen because most of the healthcare practices are human-driven and human-centric. And with so many faceted people with multiple behavior, skill sets and differing upbringing coming under a single roof, mistakes are bound to happen. Deviation of cares are a part of reality that we need to acknowledge. The only fortunate part for all of us is to create that culture of safety. So what we mean is creating a very positive organizational culture, and leaders who have been instrumental in creating a positive environment have contributed to higher job satisfaction, lower attrition, lower errors, and more importantly, complying with the overall safety culture that we need to create into. And it is all about creating high reliability organizations. So when we say high reliability organization, these are the organization increases the ability to deal with failures. I think failures and deviations are a part of day-to-day life of healthcare. So we'll spend some time on those aspects and move forward on this. So let's take a pause and understand as to in healthcare, what do we do on a day-on-day basis? So we prevent disease when possible, we cure disease when we can't prevent, and we provide care and comfort when we can't cure. One of the good things in COVID, I think that's the silver lining amongst all this roller coaster ride that we had in the last 2 to 3 years, is that the protection of staff and the healthcare provider also occupied prime importance as equivalent to the patient. So I think this has been a big change in healthcare syndrome, and obviously the ability of leaders is to protect patients and staff also from errors, injuries, accidents, and infections, which are a big norm in the current scheme of activities. So this is a wonderful thing that an error does not become a mistake unless you refuse to correct it. And I think all of us as healthcare providers, and we are leaders in all our spectrums. Everybody needs to be a leader, not only the CEO, not only the board of director, from where the mandate of the culture of safety needs to come in. But I think all of us as healthcare providers, workers, are leaders in our own wisdom and in our own potential capability. So these are 7 or 8 steps that we typically need to focus on when we talk about leadership mantra. The first step obviously is to get the access strategic priorities right in the culture of safety and identify and close the gaps. So there are a lot of offerings. We will touch base on few of the offerings on the culture of safety in the latter part of the presentation, but getting rightful priorities is very important. You can't be doing everything overnight, or you can't be doing everything at all once. So obviously prioritization is the key. The step 2 is executing. I think execution is the very important key in terms of improvement and reliability. I think we need to get into high reliability organization as healthcare providers. So obviously any transaction that we do, there is an high element of variability in healthcare episodes that we deal with. And that's the reason we need to get into a reliability matrix. Step 3 is to hire for what you aspire to become. Getting the right competent people on board. And as Gyaniji very rightly said, empowering them adequately enough and creating a responsibility matrix, which creates a sense of ownership. I think this is very, very important. Having the right manpower who will do the right job at the right time, as and when the patient and their families are needing it, is very, very important. Step number 4, which most of the healthcare providers do not do a good job on, is communicating. I think building awareness. And at times, as we keep on saying in healthcare, over communication is also something better, if not worse. But obviously communicating and creating that sense of awareness. So culture of safety is not an episode, it's not an event, it's not an overall thing. It's a process. It's the way how an healthcare function needs to operate on a day-on-day basis. The 5th step is a very important one, is to engage key stakeholders. As we all understand, there is multiple dependability between the healthcare processes. Clinicians, housekeeping staff, nursing, security guard, including the valet parking fellow also needs to echo and mimic the overall essence of your culture of safety that we talk about. Step number 6 is again, which is a very important step according to me, which is to support staff and patient families impacted by medical errors. As we always keep on saying, any organization saying that they don't have any errors or they are immune to errors, I think they must be lying or they must be under the influence of something. But definitely in healthcare, I think this is a harsh and ground reality that all of us need to understand. And this sensitivity element of supporting the staff and patient and their families who get impacted by this deviation of healthcare practices for whatever unintended or intended norm, I think all of us need to be obligated by that. Step number 7 is also very important, to track and measure performance over time and improve analysis. Another important element which is evolving very strongly is the element of data mining. Data is occupying more and more prominence, more and more as we talk about in healthcare, in clinical segments in particular, that we follow evidence-based practices. In non-clinical areas also, we need to get into a practice of following evidence-based practices. Everything needs to be data-driven, and data has an ability to show you, data has an ability to speak to you. As long as we can track and measure the performance over a period of time and look at the overall improvement analysis, what needs to be undertaken. And the last bit is again redesigning the overall system and improving reliability. I think the systems cannot be rigid, it needs to be flexible. The systems need to be agile. And I think unfortunately, COVID has really given a lot of introspection in healthcare system to be more agile and more forthcoming in terms of the overall approach. So from a leadership mantras, these 8 steps are very, very important. So when we look at facilitators to the overall leadership mantra, there is a 3-pronged approach. There will be few initiatives which are from a strategic point of view, few from operational point of view, and few from quality point of view. So from a strategic facilitator point of view, the first step is obviously to evolve yourself as a PSO, which is a concept of patient safety organization. The element of patient safety organization is that the goal and the objective is to reduce variability of care at each and every touch point of care journey that we get into. And the more important aspect of PSO is also to prevent recurrence of event. If the same kind of events are recurring over and over again, something is wrong in the mechanism as to how teams are dealing with the overall activity. I think the recurrence definitely should be reduced over a period of time. The second important facilitating factor from a strategic point of view is obviously to get into periodic patient safety culture surveys. These surveys are a good dipstick introspection as to how do you gauge yourself from a patient safety point of view. And more importantly, I think across 365 days, there should be a good communication channel of getting staff feedback. Staff and consultant feedback are really a backbone of setting up a very good patient safety culture in any organization. And a lot of it has to do in empowering and creating and removing that barriers. As Gyaniji also said very rightly, the CEO cannot be sitting at the apex and dictating terms over there. I think it needs to be a very fluid kind of communication organization where doors are always open for anybody to contribute something which can enhance the quality of safety of care and also reduce the risk if the patient or their families are posed in the terms of the work environment. Value-based purchasing program is another concept which comes as a subset of PSO. This means that the overall focus on all value-based purchasing that we are getting into comes from an outcome point of view. Commercial elements are important, but definitely it is the overall obligation of the clinical outcomes that we need to keep on focusing on, look at evidence-based practices, look at those kind of things. Incident reporting also is a very good tool as long as it is used appropriately and used very objectively. Root cause reviews and corrective and preventive actions are something which are a norm with most of the healthcare provider, and they have been doing a very good and decent job at it. Another important element based on the variability of the healthcare system is to hardwire your hospital information system. So as long as we can have tools and technology which can help create a clinical decision support system for our healthcare provider, which will enhance the kind of quality of care, and more importantly, standardized care practices also. So look-alike, sound-alike drugs that we talk about, order sets which get integrated into the system, drug-to-drug alerts that we talk about. These are all cohesive abilities to influence the overall outcome at an episodic level and create that kind of confidence with the care providers also within the culture of safety environment that we talk about. Tracers, audits, and surveillance are a part and parcel of any healthcare system, and that should be something where the rigor should be there. And again, the overall approach should not be to get into an postmortem or audit finding or fault finding mission. The overall intent should be always to get into constructive feedback, which can enhance the overall quality of care and reduce the redundancy of recurrence of those kind of events, which need to be tied up in the ecosystem. Likewise, from a strategic point of view, operational parameters are also there, multiple elements, as we all understand in healthcare. The room design and the layout itself can be a good facilitating factor in terms of creating the culture of safety. So one of the questions which most of the leaders should be asking themselves is, are you giving the right tools and mechanisms to your staff to ensure that A, they are themselves safe and they are confident and competent enough to take care of the patients and their families. So all these elements that we talked about, whether it is air filtration, looking at patient movability element, looking at computer on wheels, point of care activities, at the first instance, how it can be made nearer to the patients are certain of the things. Addressing staff and consultant fatigue syndrome is something which we have learned the hard way in the last 2 to 3 years during COVID. And definitely it is here to stay now. At times we do get overworked on multiple activities. There is an effort level being put in by multiple care providers, and that is something which needs to be, all of us need to be cognizant of the fact. The third important element, again, I think this is where real leadership comes into play. At times, there are senior staff members or consultants who get into a very unprofessional and abruptive or disruptive behavior practices. The ownership lies on the leaders to intervene and correct those kind of behavioral practices. Because definitely if somebody is getting scolded or somebody shouts, if a staff makes a mistake, they're bound to make more mistakes. This is the simple common sense which all of us need to understand. And hence it is very, very important, independent of the hierarchy in the organization, this kind of incidents, A, need to be reported and B, need to be addressed in a very professional and cordial manner. Shift changes, handovers, there are a lot of loose gaps which need to be tightened. Family meeting, patient education is again something which enriches and encompasses in setting the expectation right. As we all understand in healthcare, setting rightful expectations is the key. As long as we can set those rightful expectations, not only with the patient and their families, but also within our staff, within our overall team members, it is also very important. Hourly rounding or periodic rounding by the senior management team is of very, very important element. That is where, while PowerPoint presentations, boardroom meetings are good, as we all always say, I think the real action happens on the ground, at the floors, inside the OT, inside the ICU, inside the ward area. Clinical grad round is another avenue for clinicians to share few of the best practices that they do and acknowledge and share those kind of best practices with their fellow colleagues across. And rapid response team, for in case of any eventuality, obviously most of the hospitals have those kind of code teams and this thing. From a quality point of view, again, staff training orientation is of very important element. We are human beings, we are knowledge workers. So it is very important to brush up our skills every now and then in terms of whether it is technology, whether it is on-the-job training, whether it is classroom teaching. In terms of this thing, committees do play an important role in getting into collecting the data, looking at meaningful ways. And the best part about committees in healthcare environment is you get a multidisciplinary approach and input, and collective wisdom, as we all understand, is always better to get into prognosis or review of individual problems which are coming in. Peer reviews are the norms which within Apollo we follow very, very clearly in terms of this thing. So at periodic interval, if there has been a deviation of care, we encourage to get into peer reviews in terms of getting into a very candid discussion. And peer reviews are also important because you need subject matter expertise who can give you insights in terms of the overall prognosis as to what has happened or what has gone wrong. Upkeep and hygiene plan is something which becomes a norm into day-to-day healthcare environment. Data analytics we have already talked about, and more importantly, as a work culture or organizational structure, it is very, very important to have a unit-based quality team and safety teams, so that people are empowered rightfully and so that they can take care of their day-to-day activities and work. This I won't spend time, but this is just an indicative list of the quality indicators which most of the healthcare providers track. And this is again evidence-based, this is quantifiable, and this is tested and tried out at periodic intervals. And obviously, the overall outcomes itself will give you a good barometer or a checklist as to how the organization is faring on the safety culture. Again, I think as healthcare providers, we need to identify and create opportunities to celebrate, create awareness for learnings. So these are again an indicative list of multiple awareness or event week that we can create within the ecosystem where people come, enhance their understanding, do away with any kind of apprehensions or wrong definitions that they had in their mind in terms of any other particular things. And obviously, a mistake you see and do nothing about it is definitely something which I cherish this sentence very much in terms of this thing. JCI has interestingly put a very good definition of safety culture. So as indicated in the JCI definition, it is not only in terms of the system process, it is the whole ecosystem of belief, value system, the attitude that your staff shows, the perceptions that we carry, and more importantly, the pattern of behavior that we bring on board. So even while we may not speak, our body language itself can contribute to the overall safety culture at periodic intervals in terms of this thing. So to sum up, improving safety culture, obviously we need to identify cultural gaps in terms of safety or culture gaps, undertake staff and consultant feedback at periodic interval, get into tracer audits, encourage teamwork training, which is very important. Rounding by senior management team and junior management teams are very, very important. Units-based quality and safety teams who can take the ownership of the portfolio of the work that they do. And the last and the most important work is work and life balance. So at times in our enthusiasm, we have two extremes of staff. People who are so committed to the organization that they don't want to go home, and people who are so committed to their homes that they don't want to work at the workplace. So I think there is a fine balance which needs to be there in terms of this thing. And obviously, not having a good leadership can lead to increased frustration, communication breakdown, which is an essence of this thing. And data, again, I think I will harp more on getting the quality goals done at appropriate interval, regulatory monitoring in terms of this thing, and enhancing care. I think these are 4 or 5 perspectives in terms of this is all what I had to present. Thank you.
Thank you so much, sir. I think no one else can explain the safety culture better than you, sir. And I've seen, as a first-hand, while we were working in the same hospital. So I think errors and mistakes are bound to happen in very complex healthcare scenario that we all are working in. So that's usual. But how do we keep our communications channel open? How do we engage our people? And how do we, support our staff who are impacted by errors or mistakes? I think that is the, key message that we have got. How do we develop our organizations as a patient safety organization or high reliability organizations where we deliver, certain type of patient care, without any mistakes, in a very predetermined manner? I think that is very, very important. And taking and obtaining feedback not only from the patient, but also from our doctors, our staff, and our frontline workers. I think that is very, very important. Also, how do we learn from, adverse events, the actual incidents that we are, getting in our hospital, also plays a very key and crucial role in building and sustaining patient safety culture in the hospital. But then at the same time, how do we deal with any disruptive behavior or reckless behavior that we generally call? So that also we need to have in balance. So I think a lot of messages that we have seen through in this beautiful presentation by Mr. Marathe. So thank you so much, sir. I think that's the end of the session. Now we are opening up for a couple of questions. I think we still have 5 minutes. We can take probably 1 or 2 questions. So if you have any questions, just quickly write into the chat box, and we will get it addressed through our esteemed speakers. So I think there is one question which has already come. Dr. Bharat has asked that how does a leader fix the culture of a hospital, since the culture is abstract and difficult to understand, and change it? So what suggestions do you give us? So I think Mr. Marathe, you will be able to answer the question, please.
Yeah, I think as we all understand, I think culture is definitely a very vague term in terms of understanding and this thing. And I think it is always a matter of every act, every day that we come at work. I think each and every episode of our interaction, how the staff greets you at the doorstep itself, how the overall sense of urgency is being demonstrated by all care providers. Have we provided the rightful tools, as I said, infrastructure wise? Do we have the right ability to deal with those kind of eventualities while building up a hospital setup? And more importantly, as I think all of us understand, it is a top-down approach. It comes from the board. Definitely, they need to aspire and have a very clear cultural vision in terms of what is the culture of the ecosystem that we need to create upon. But definitely, once when culture gets into the overall system and people make it a point to make it as a way of working, I think it is contagious. When you see good smiling faces, when you see people who are helpful, resourceful, wanting to take that 2 extra step to help out a patient or guide a particular friend also, frankly speaking, culture of safety has nothing to do only with patients and their families. The culture of safety has a lot to do between how we deal between ourselves as peers, as colleagues at work. I think that whole sense of positive work environment is very, very important to create that kind of culture. And again, as asked, it does not come overnight. It takes time to evolve. It takes continuous hammering of the fact that at each and every touch point, we should start asking logical questions while taking any decisions at work. Is it fitting into the culture of DNA, what we are aspiring for? I think this is something which we all should acknowledge. Whatever activities that we do at work should be resonating the same brand or the vision, what our chairman or what the board member has in mind. I think this is a simple summation of.
Thank you so much, sir. We have another question, I think, for Dr. Gyani. We need to hire competent staff, including doctors and nurses, etc. But how does a leader assess this competency of a candidate, since the hiring process is usually and largely verbatim through interviews? So how do we actually evaluate their competencies? So this is what the question is, sir.
Usually, there are 2 things, what we call the medical, credentialing and privileging. Now, credentialing is very simple. There are set rules that no doctor can join unless he has got MBBS. No specialist can be there unless he is MD or DM. Similarly, no nurse can join unless she is GNM or BSc. So that is a very simple part. And this provides in the regulation that you can't employ doctor or nurse without so-and-so qualification. Okay. The privileging is more important. That is the role of leader where he comes, Because a new surgeon, what kind of procedures he can be allowed to do independently, without any supervision and with the supervision. So, this is where, I was telling in my talk, the role of specialty HOD is very important. Earlier days, I think Marathi also will remember, if you go 20 years back, in each specialty, the surgeon used to sit together over the cup of tea, if not every day, at least once in a week. They used to discuss what are the procedure you did, what are the procedure I did, what I learned, what are the problems, how do I face. Unfortunately, today is not happening because everyone has got so much work to do. They do the surgery and get out, and that's all. They don't even talk to each other. That is where each HOD must hold, if not every week, once in 2 weeks, meeting of all the surgeon and all the physician with him. And they will take up their own cases, make a presentation with the team. They must also invite the diagnostic people, administrative people, corresponding nursing staff. In this department, then you will really be able to groom the new surgeon and new physician with the competency what we are looking after. Because CEO alone, he is not competent itself. Sometimes he is non-medico, he is maybe a medico. So the best thing is he get HODs to do this work and review them once in 2 weeks. And at least once in a month, all HODs then sit together along with the CEO and then bring out, because here, not only clinical problem, but also the managerial problem, they will be able to bring out. So I think the privileging comes through the shared decision-making and through what I'm calling it operational meetings at the level of HOD. And that is the way you build and you privilege the individual surgeons and physicians.
Thank you so much, sir. I think very well explained. though there is a time to end the session, but there is one question which has come up from Dr. Dipali, and I really couldn't stop myself to ask the question to Mr. Marathe, which is very relevant. How to overcome resistance to change in hospitals toward improvement of quality? So how do we overcome the resistance?
I think, as we always try and understand and say, change is the only thing which is constant in the overall system. So I think change is something, I think we need to be a little bit, there is a whole structure of change. I think the general tendency of human beings is definitely not to adopt change. I think that most of the people typically are averse to change. If things are going good, definitely nobody wants to change their existing norms in terms of how they work and this thing. I think there needs to be a cohesive process, and obviously the first of the larger picture, what we need to paint is why the change is required. So if we could show them the bigger picture as to why this change is needed in terms of what is the overall positive outcome on the patient care activities or based on the family education that we can provide for, I think most of the people buy in. As long as they get a clear visibility as to why a change is needed, I think most of the healthcare provider, including consultant, my experience shows that they are willing to buy in, they are willing to listen in, as long as we can put a logical business case saying that this change is needed for this things. Second important thing, when we do change, I think one of the responsibility as leaders is to have an element of equity and distribution of across the organization. You can't be deliberating change only in isolation for a particular segment of people or for a particular set of clinicians. I think this will be unfair. So as an equal opportunity employer, I think that second ownership also needs to be made to all. So there is less concern if the overall change is applied across the organization. Definitely everybody will receive it in terms of those kind of things. And more importantly, I think if you could also show how it will affect the outcome and efficiency of the individual staff while undergoing this change. If the burnout ratio can be coming down, or if the efficiency factor can be more added, if we can get into better accuracy of outcome of the cases that we are dealing with. I think all these are facilitating factors, but definitely there needs to be multiple discussions, and a sign off and a buy-in is needed. Again, communication here is very important. The way healthcare works also, and we also at times say that we like surprises only on our birthdays. Apart from that, we don't want surprises at any point of time. So one of the important element of change is we need to be proactively communicating those kind of changes, current scenario and the future state as to what we are aspiring to get into very, very clearly to all the stakeholders in the hospital.
Thank you. Thank you very much, sir. I think because of the paucity of time, we will not be take up, the questions that you are asking now, since it's going to be 4 now. So thank you very much, Dr. Gyani and Mr. Marathe, for your precious and valuable time and the perspectives and the views that you have shared with the entire audience. I think that is very, very informative and very, very valuable.
Thank you.
Thank you everyone who have joined for this webinar today. I think we had more than 300 participants on Zoom and a couple of participants on YouTube Live, which we are also holding this webinar at this point of time. So thank you everyone for joining today for this webinar. Before we go today, let me also tell you about tomorrow's webinar. So since this is going to be a series of webinar, so tomorrow we are going to have very important webinar on fire safety principles, where experts from Narayan Health will take us through various relevant and practical aspects of fire safety principles. So please register for tomorrow's webinar. You can use the same link, but you need to register it separately. That is the request. We also have our 9th International Patient Safety Conference, which is coming up on 13th and 14th at Hotel Taj Palace at New Delhi. So kindly register. This is going to be a great network opportunity where you would be amongst around 1,500 delegates, more than 200 speakers from various countries, and more than 50 sessions in 2 days on 13th and 14th. There will be exciting and very informative patient safety exhibition. There would be patient safety awards, papers and posters, and many other exciting activities. So please do not forget to register for the conference. We have also given the details of our email address, our phone number, as well as the website into this slide. We also have 5 pre-conference workshop on 11th of February at Indraprastha Apollo Hospital in New Delhi. So please register for it. The registrations are still open on website. We also have our conference application, which is International Health Dialogue. So please download and install that application, which is widely available on Android as well as iOS. So with this, we thank you each and everyone, for patient listening and attending this particular webinar. Thank you so much, and we'll see you tomorrow. Thank you.